Now this is a case of subluxation. This is a post-traumatic case, and you can see the visible subluxation probably is only 60 to 70 degrees, but we will ask the patient to look in different gazes and we shall actually estimate what is the extent of subluxation. So the subluxation in traumatic cataracts is actually non-progressive, so they are a little bit more forgiving. Beta is taraf ko aankh ghumaiye. So that is your level of subluxation here in this area. सीधा देखिए बेटा, अब नीचे को देखो बेटे पाँव को. Now that is your subluxation there. इधर को देखिए बेटा, इस तरफ को देखिए बेटे. Okay. So this is the only area which is same. लाइट को देखेंगे प्लीज. इसमें विपुल वगैरह किसी को स्टैंड बाय रेटिना के लिए रखने हैं. Okay. So we will proceed. I have shifted. I was initially planning to operate it from the temporal side, but on seeing the subluxation in my area of working, I have shifted the position of working to superior. Now we will make the ports a little longer because we don't want a leaky wound. So my incisions will be slightly longer than normal. There you are, slightly longer wounds. I would want to, though even though I have a good glow here, I would want to stain. Okay. लाइट को देखिए. So the reason why I have stained is because when I am about to put the CTR or a CONE, whatever would be required, I would need a better visibility. The trick here is not to over pressurize the anterior chamber, otherwise I will break the anterior vitreous space and land up in a problem. So needle. Now the trick is always to have a slightly broader rim of Capsulorhexis in the area of subluxation. Now we will start with making our Capsulorhexis. हिलाना नहीं बेटा आपने. You will notice the rhexis doesn't have to be very large, otherwise the CTR will tend to come out of that zone. Now we want a slightly longer flange here. Visco please. So this whole area right from here till here is subluxation. We will just keep forming the anterior chamber, but forceps. नहीं बेटे ऐसे हिलाए नहीं आप. There. Now the trick is not to do a very aggressive hydrodissection, but yet be able to complete the cleavage of the zone between the cataract. So yeah, this is exactly what I was looking for. If I could deliver the cataract out of the bag in one go. Power 10. Now the only thing is we don't have to break the occlusion. बच्चे viscoelastic आपका ready रहना चाहिए. And at no point fluctuation of the anterior chamber. Bottle height should be slightly low. So we will try and wheel out this cataract out. That would be the safest bet. So at least in case the cataract sinks, we don't have to go and fish it out from the So I am carouseling the cataract out. So I will do the carousel technique here. I have tilted the phaco tip, and there you are. You can see the cataract beautifully come automatically into my phaco probe. You have to be very careful at this point because the vitreous will try and come out from the subluxation. No pressure fluctuation. So just before your occlusion breaks, reduce your vacuum. Visco ready. Visco is ready. Now we will actually introduce the visco into the bag. This doesn't have to go into the anterior chamber. You notice I am pushing it into the bag, and do not over pressurize it. Now this distends the bag in an angle. Now we will go in for placing a CTR.
Motorlight 120, vacuum 480.
CTR. CTR. Now we will place a CTR. So we have done a measurement of the white to white. The measurement is 11.76. So I would like to go in for the 13 millimeter CTR in this particular case. Yeah. Now the direction of putting the CTR will be छुट्टी उठा लो थोड़ी दोस्त center. So we start by pushing the CTR very slowly. The direction of dialing is tangential. These can be very, very tricky situations. It has to be a very controlled dialing. Forceps, tooth forceps or suture tying. Yes. You have to keep dialing, making sure it doesn't come out. This is a dialing like a railroad technique. सिंसकी बेटे अब आप आंख बिल्कुल नहीं हिलाएंगे. Go and tilt your Sinsky. There. Hopefully we are in business. Now this is a large subluxation, but somebody may ask me why didn't I go for a Sionis? I would have attempted with the CTR ring. In case the ring was not adequate, I would have gone in with the CT segment. Now the next part of the trick is removing the cortex from behind the CT or the ECR. So we have to do a tangential peeling, never a radial peeling. No movement like this. We have to go side to side because we might break some remaining zonules. So again you will notice a tangential movement of the zonule of the cortex removal. Now this is usually a tricky part. You can use a bimanual IA if you are comfortable. I am comfortable with both, so I would sometimes use a bimanual, sometimes I get away with. Now, as I said, this is very, very tricky. Radial movement to loosen the cortex. There, slow peeling movements. The advantage of using a bimanual is you can use a second instrument actually to pull away the iris and get your visibility, which sometimes with the coaxial advantage of coaxial, which sometimes in a bimanual you cannot do. Visco. Now before I remove my irrigation aspiration, I will do a visco exchange. Again into the bag. लाइट पे देखेंगे आप. So I would rather put the IOL. Now the angle of placement of IOL is always maximum part of the haptic should be facing the maximum area of subluxation. So we will introduce the IOL in the area of least subluxation and then slowly, that is the reason I shifted from the temporal incision to a superior incision. Now before my haptic can unfold, I will rotate the lens at an angle which is in the area of maximum subluxation. There you are. So bottle light कम कर दीजिएगा. Now we are going in with the bottle height. We are going in the bottle height, and then we will see that the surgery has been done beautifully. The IOL is absolutely centered. There is some amount of residual cortex. We will try and go for it, but in case we cannot take it off, we would not risk losing the bag. So the advantage of having one spare instrument, I think it's stuck badly behind the sometimes this can fluff up and come after a couple of days. I will again attempt it slightly. I am able to peel some part of it, but that's a very risky proposition here. There, I've taken out a major big chunk of that. गर्दन थोड़ा सा धीमे धीमे centration, IA, hydration. Now again we'll have to make sure that as I come out I keep the anterior chamber hydrated. There. So this iris protruding out sometimes is helpful for the surgeon because it will ensure that the IOP doesn't come down suddenly. So there you are, the surgery is gone off beautifully, and I think we will not need a CTS segment in this case. There is a slight amount of ooze in the iris zone where I pushed it back. ADR. So in case there is a ooze from the iris, you can use some epitrate or adrenaline there in such situations. It tends to stop it. So there we are, the case has gone off perfect. We hydrate the wound, never over pressurize such wounds. It's sometimes you may want to be or be tempted to put in some air bubble. I usually avoid air bubbles in such cases. So I avoid air bubble in such cases because sometimes they can actually break the zonule and go behind and then cause a complete loss. What you're seeing a little bit of haze you're seeing is due to some amount of ooze coming in from there. So we wait for the ooze to settle down. अब पालो दे दो मेरे को. So there you are. Surgery is gone off perfectly. Even though there is some small amount of oozing there, so we are lucky, we are safe that this will clear down by tomorrow. That's due to the manipulation of the iris when I was trying to push it back. Sinski देगा बेटा? थोड़ा सा विस्को दो. I will push some visco in that area to stop the oozing. Meanwhile, I'll try and manipulate my iris because it has been stuck there for a long time, so it's little atonic iris there in that area. If you plan to do this maneuver, do this very gradually. We don't want another iris bleed. So we just wait for some time, and when the ooze stops, we can wash the viscoelastic and finish the case. Thank you. The ooze has stopped. We will try and make the pupil round by slow nibbling and pulling on the iris. And then there we are, surgery being over. We will again, before we pull out, light. So it's a floppy iris. There you are. Okay. Surgery.